Yes.
Okay.
Yes. Ladies and gentlemen, welcome back to our international ground rounds. So we have a guest today, Serkan Gode from Turkey. Good morning, Serkan.
Good morning, my friend. Nice to be here again.
Thank
So
you.
now we've solved the problems.
Yes.
Yeah.
So today's talk is going to be focused on
Ladies and gentlemen, welcome back to our international ground rounds. So we have a guest today, Serkan Gode from Turkey.
Exactly. So what we will do today, would you please just stop sharing your screen and we will go back at it again. Today's talk is focused on how to master the use of rib cartilage and why it is important on the use of a daily practice and also on revision cases. Rib cartilage has been many times used for not only reconstruction for functional purposes but also for aesthetics, and especially in complex cases such as secondary cases. Today's talk will be on a step-by-step procedure on how to harvest rib cartilage, how to use it by one of the master. So please, Serkan, once again, share your screen and let's dive into this. I remind all the attendees to ask your question and type your question, and those will be delivered at the end of his talk. Thank you.
My friend, thank you very much for your introduction and invitation at the same time. Now, I'm gonna speak about rib harvesting and my technique. So I will start quite fast, and so I'm gonna close the speakers, turn the speakers off. So if you wanna say something, just raise your hand. I'm gonna open it because some videos are with voice, so I don't wanna mess up everything. Now I close my speakers. Now I'm gonna just try to explain myself how I do it. Okay. First of all, I do a small incision in rib. Okay, you can do it if you're gonna get a like fifth or sixth, depending on the breast size of the patient. Or in males, you can direct all is visible, so you can directly go to the seventh, which is safer and straighter and longer. So basically, if I can choose, I choose the seventh rib. Why? Because under seventh rib, generally there is only diaphragm, not too much lung tissue, so it's safer and it's longer one piece, not curved, because curved ribs are like sometimes cause more problems. It's in females sometimes very thin. You may need to go to up to sixth from the same incision, but generally if I choose, I choose the seventh rib. I do 1.5 centimeter incision. I'm gonna show you how I do it. This is generally my incision, and this much. So because you need that much incision to take the rib out, okay? Otherwise the rib doesn't come out. We pass the section planes. This is fat. Always I get a little bit of fat because I mix it. I'm gonna show with scratch cartilage of the rib to put to the like on the dorsum in the end of the surgery with some antibiotics and PRF. And also, this is my incision. When we go inside, we get the fat out and then we see the fascia. You can directly, this is my small finger that goes in. It's already just small finger width, okay? And then, as you may see, we go directly to harvest the fascia. Rectus abdominis fascia is very good to harvest. You can use it as camouflage or subcutaneous tissue replacement in rib revisions. So always a good idea to take some of the fascia out, okay? Rectus abdominis is a good one. If you need too much fascia in special cases, like in cranial base we do, you can go to fascia lata. This is rectus fascia, how I harvest. And then you see the muscle directly. And then we go just directly to the muscle. I use an Alexis retractor. This is Alexis. There's a small ring and a bigger ring. Small ring inside the muscle. Okay, as you see right now, under the muscle. Don't open the muscle too much. Don't cauterize it for pain management. You put it under the muscle. Now the small ring is there. You will see how I use it. Now you just flip it around with your nurse. Your cylindric dissection plane is now conic. You can manage it one hand by yourself, and exposure is good. Muscle and fat is not around. It's very nice instrument. I recommend everyone to use Alexis retractor. 1 to 3 centimeters. Alexis is XX small size, so you may need to get the XX small size if you're gonna use a small incision like me. And this is how we see the rib and remove. I'm gonna show the details. We use a small hook to get the rib out. It's very clean surgery, and in the end, you take the rib. Sometimes it's the hardest thing to take the rib out, as you may see, because a small incision already almost the rib is the same size. Okay. Then you get it out. Yes, as you see. Then another thing, for example, same 1.2 centimeters incision, same Alexis. I always use the same method, same technique for rib harvesting. Another one, this time the patient doesn't want a visible scar, so we go to the boob because she has enough boob size. And so the breast size is enough. You can get 6th or 7th from the same incision. Here you see, first of all, we have to preserve the underlying perichondrium and the rib. Never push down. Okay, always ask your anesthesiologist to be around, to be awake. Okay, before doing this, and never push around. Be in the right plane. If you see whitish things like that, no bleeding, you're in the right plane. If you start to see bleeding a vessel, then most probably there is a synchondrosis and you are in the intercostal area. The vessels are in the intercostal. So under the medial to the perichondrium, there is no big vessel. So if too much bleeding, you are off the dissection plane. Okay, so you have to come back to the rib. Look, I never push down. I always dissect the mucoperichondrium. Gently, gently, no rush. These are very aesthetic surgeries. We don't want any complications, serious complications like pneumothorax. So we never push. This is an unedited video, how I do it video. And you can see here, I use this instrument rather than scalpel. It's, you go under the rib, little dissect with this dissector, special C dissectors. And then you cut with those, not scalpels, but those osteotomes, let's say, or periosteal elevators. So you remove it. Always I do the same thing. If you can see the underlying mucoperichondrium, it's very clean. Never push. If it bleeds, you are off. Go elsewhere and find the right plane again. This is the most important thing about rib harvesting. And then when I cut in oblique split. For me, for L strut, we do almost always oblique split. But if you are gonna do a tip graft, then you can sculpt according to your taste. So generally, when I'm in very bad cases, I take 2 ribs, 7th and 8th, for example, or 6th and 7th, depending on the size of the patient. Then I get 2. I use 1 for bridge L strut. I always chop it like this, oblique split. But if I'm gonna use it like a tip graft, 1 piece, so I sculpt the graft of 8 rib 1 piece to put in the tip. This is when I'm taking the rib, always I take fascia, fat, perichondrium. Okay, these are very important, not only cartilage. Cartilage can skeletonize in very, very much contracted skin cases. So this is what you have to use also on top of the structure you do with the rib for soft tissue management. Like here, I can show I use fascia under the incision. I use fascia above the ribs. I use fat under the incision point here. This is 4 times operated patients. Yeah, you may see that I use a lot of soft tissue replacements also from the patient from the same incision. Okay. And also you can use fat with scratch cartilage like that, and you can prepare a diced cartilage material with some rifampicin antibiotic on it. I chop it like this. This is very good camouflage material that you can use in the end of the surgery. You can just push it inside the cavity. This is a live surgery person, and I'm gonna show you with the endoscopes how I take the rib if it's possible, if I have time. Yes, we go in, we pass the planes, the fascia. We always get a piece of fascia, and then under the fascia, we cut the perichondrium. I always recommend you to get the perichondrium on side. I mean, like, first take the perichondrium outside. It's because the rib is stable right now. You can do it very easily. The outer perichondrium, you can take it out. Yes, nicely. You can use it as a camouflage material or a material to cover the ribs. And then gently with the osteotome, with the periost elevator, you can do the cuts on the sides and put the instrument under. Wait, I'm gonna show you something. If you dissect all the way this side and the other side, you will be on different planes, okay? Because perichondrium is not one layer. There is soft cartilage around the perichondrium. So I recommend you to do it once under the rib, then cut the sides. It's very easy. Let the rib popping out and doing its own dissection. Then it's gonna be one piece dissection plane. Otherwise, you go this way, that way around, this way around, then you cannot merge your dissection planes easily. So put the instrument now, cut the side. You see, I don't dissect the underlying. Now it pops up. Very easy. It pops up, and this you are on the same dissection plane. Then synchondrotic parts, everything. Then you remove the rib piece. Okay? It's very easy. It's a safe method. I did maybe every year I do. This is endoscopic view of the inside. This is oblique split. Have you cut it? There is almost always a kind of, because the rib is not septum cartilage. Let's stop here and speak about rib. Rib diffusion capacity is not as good as septum cartilage. Okay, rib has Haversian canals inside. Rib has a structure like bone and it can get calcified. Look, there is blood vessels and blood structures inside the rib. So, to tell here, rib is not same as septum cartilage. If you crush it, if you just scratch it, if you just divide it into 2, 3, 5 pieces, this doesn't mean that it's gonna behave like septum and it's gonna get diffusion blood supply very easily. No, it needs a structure and it needs time. So because of that, rib revisions can fail and fails very bad. Okay, so you have to be very precise to use rib, very clean, and also, for example, you have to have an idea how to feed the rib. It must be under skin or mucoperichondrium. You know, you cannot use free grafts, rib, open rib, exposed cartilages. No, you have to cover it with something for blood supply. This is very important. Septum cartilage. I've never seen septum cartilage extruding through the retrocolumellar perforation. But I saw hundreds of cases like rib revisions. The cartilage extrudes back of the columella inside the nose, opens the mucoperichondrium because of the rib resorption is not just resorption or rejection. It is something that we have to think it's a structure which can get blood supply easily or not. So you have to have like a construction, a building. You can construct a building. It's the same way. You have to have a plan. Oh, sorry. Sorry, guys. Let's move on. So cutting it obliquely is a good way to just use the cartilage. And it's very strong way. I put everything in I don't use only grafts in the bone to stabilize. It's a matter of different talk. But to rib harvesting, I can tell you that this is the way that I use, and to use the rib as a oblique split is the best way I can see. Why? Because the patients ask, even, let's stop here. The patients ask, hey, what do you do for rib not to warp? First of all, you fix the ribs in the bone. Second, you cut it oblique split. Third, you laminate few grafts together. You know, if you use one piece, if it little warps, it warps. If you don't fix it in the bone, like extended spreaders, it can still warp and it can bend on the top, you know. It's free graft, free dorsal onnate. So put it in the bone, use multiple grafts, and use oblique split. This is the way that you can do most for your ribs not to warp. Okay, bone to bone fixation, and also oblique split and lamination with multiple grafting. Let's move on. So let's say oblique split, can it be the perfect way? Sometimes no, because rib is not uniform. You see, some parts are calcified, some parts are not. So there is no uniform thing about rib cartilage. But as you may see, we cut it into pieces. These are very nice pieces. You can use extended spreader, septum extensions. And if it's bony, you can use also piezo. If it's bony, if you cannot cut, use the piezo to cut it. As you see, that kind of graphs, at least you need 3 perfect graphs to have a nose. If you don't have 3 perfect graphs, then you can fail. 4 is better to have a replacement, you know, but 3 at least you need. So this is how I do my rib harvesting and rib chopping. If there are some questions, for sure, it's my pleasure to answer. Thank you very much, by the way, Puya. Sorry for being late because of something.
Oh, probably it was a problem with the connection. So let's stop sharing and let's focus on a few things. I go one by one from the questions. The first one is that when you opening up the skin, how you making sure how to avoid nerve and vessel injury? First question from France.
So first of all, which nerve you mean in the skin incision? So the question.
So I don't know how I should type it from the audience. I think, without wasting any more time, I think that the question is how to recognize the skin incision if we are exactly in the perfect position, and how to avoid sub rib.
Okay. First of all, the last common rib is the 7th rib. Okay, 7th rib has an attachment for 2 ribs. The 6th, which is synchondrotic mostly, and the 8th rib. 8 is very short and on the lateral part. Okay, so when you feel in the middle, just under the nipple, the last common rib is the 7th rib. It has 2 attachments, 6th and 8th. Okay, so this 7th rib is the gold standard. Less risky, longer, and especially in males, very nice, very thick, very good. So you can directly put your incision on top of it. Never be too medial in the 7th. So let's come to the chest. Can you see my chest right now? If you're gonna take the 4th, be medial. 5th, 6th, 7th, go lateral. Always go lateral, because the ribs are the cartilage part is going laterally. Okay, so how am I gonna be sure? I can tell you, you can be sure if you feel the rib on the last one, just put the incision on top of it directly. Don't be in the midline. The cartilage is not in the midline. It's just under the nipple. Few times when you do it, 100% you will find the best place to do it. But in some people, the bony part is closer to the midline. But in many people, it's a very long. You can get up to 7 centimeters, the 7th rib. But don't forget, it has synchondrosis to 8 and 6. So you have to solve it. It's not like very easy one piece, whoop, pop up. No, you have to cut it with instruments. So nerve injury, I never heard about nerve injury in the rib, but you have to be very careful because it's a deep surgery. I mean, complications are serious. Never do it in small rhinoplasty rooms. Do it in big hospitals, okay? So if you do it in a hospital that you have no access to cardiothoracic surgeons or intensive care units, you're gonna be in trouble. Never happened to me, by the way. There is a way of having it very safely, but if it bleeds, believe me, you are in the wrong plane.
think that what you just said is important. This is the tremendous amount of rhinoplasty procedures move forward too much, but usually some of our colleagues are pushing too much their boundaries, and if you don't have a backup plan, make sure that you might get in trouble, and have always someone that can deal with pneumothorax or a nerve injury or vessel injury, or those are the stuff that we don't want to. So now the message is for the resident and for youngers, make sure to start day by day and having a backup. So this is most important. Question is coming from Brazil. How should be the length of the portion that you're harvesting? I think that the question is, how much should be the length of the rib that you take?
If it's less than 3 centimeters, you cannot use one piece grafts. If it's 3 centimeters and good thickness, most of the noses you can do with that graft. Oblique split method. The question is this: if it's a saddle nose, if I'm gonna use extended spreaders, which is higher, then the width is more important than the length. Okay, the width of the cartilage. But generally, to put them a little higher, one piece in the middle, one piece, we can manage this. And length, at least 3 centimeters. I recommend you to get 7 centimeters, 100%. You're not gonna use it 7 centimeters. There's no noses like that, 7 centimeters from radix to dorsum. Impossible, but you will use almost mostly like 3 centimeters to 3.5 centimeters extended spreaders, and 1.5 to 2 centimeters extension septum grafts. Then you can build any nose that you want, masculine or either a feminine one. So 3.5 is great. You don't need more. Don't risk too much.
Another question from Germany. What is your experience for alar button grafting?
Okay. Alar button grafting, I never do. So let's assume we have a primary case, okay? We have a primary case and then we collapsed. Why? First of all, we collapsed. There are 2 reasons. If your septum is not straight, you can have one side collapse, okay? The resting angle is not same. The second, lower lateral crus has a width, okay? This is from cephalic turning point, which is the widest, and the caudal turning point. There is a width of the lateral crus. If you narrow the lateral crus, not getting the bulbous part, but getting all the way, narrowing the resting angle, this is a big problem. You will end up with a collapse on the internal valve, where the lower lateral crus rests on the upper lat, because you release this boundary. So I recommend in the primary surgery to do medial cephalic excision, not all the way lateral. Okay, this is very important to have the idea. And if you had it, Eller button will not work. I'm sorry. Yes, this graft has been told many times. First of all, aesthetically is not good. The second, it can give you more volume, yes, but generally it's gonna collapse in the internal valve, because it doesn't. First of all, you use it for on top of everything. It doesn't work like that, because there is a scar tissue already happened between the upper lat and lower lat gap. We created it before. So I recommend full tip plasty with the bridge plasty, rather than putting a small aller button graft, because those people will not breathe better.
Another question from Egypt. Is there any post-surgical management or suggestion for the pulmonary rehabilitation? I don't understand the question. I think I'll type it again, but let's make sure the question are made proper. So the colleague is asking.
So I think or something.
So he's asking what are the risk avoidance that should be should be suggested after surgery for those cases for rib reconstruction?
Okay. Okay, rib revisions, believe me, can move like normal normal rhinoplasties. They have no restrictions, but I recommend something for pain management: walking. Walking, you just use the muscle, but you don't force it. Walking regularly every day is very good for pain management. I don't do marcaine, but don't burn the vessels. Okay, you create ischemic pain. So there are some emerging vessels through the intercostal to the muscle, pectoralis and rectus abdominis. So those vessels, if you cauterize too much, you will have an ischemic pain. So for pain management, I think it's the best way to use Alexis without any cauterization, burning it, monopolar. I never open monopolar in any of my surgeries. So don't burn it too much, don't cauterize it too much. For pain management, you can use Marcaine, but I don't use it. Alexis is a good way. You don't touch the muscle too much or you don't cauterize too much. It's a very clean surgery. You can use it, try it, you will love it. For after the surgery, I don't use any like movement restrictions. I recommend and I just encourage patients to walk. It's very good.
So how would you connect? What needle or what suture are you using to connect each graft to each other?
This is a good question. Never use Prolane. I can say this. Prolane in a nose, how it extrudes. You know, Prolane from otoplasty, we had, all of us had this. In years, it goes out. Same thing for the nose. If you're a 2-3-year-old surgeon, I mean, your like surgery years, you may say that, hey, Prolane doesn't cause any problems. I say I'm 46 years old, Prolane is problematic, stitch in the nose. Don't use Prolane. Use PDS monocryl. These are very good enough. You will have your fibrosis to keep them together. Don't worry about it. If you rely on in your mind stitches, your stitches will, under contraction, will cut like a cheese wire, affect your cartilages. This is another problem for the ribs, because to cut the rib, sometimes two pieces doesn't go and it resorbs. You know, I told you rib is not the same as septum cartilage. Septum cartilage is uniform, no vessels inside. But rib is not like that. Rib has a structure. So basically, my answer is you use PDS or monocryl. It's the best way to treat the cartilages of the rib, and use as least as possible stitches. Never transmucocutaneous, never.
So never use a suture that goes side by side.
Never, never.
Okay.
It's gonna create too much scar or an infection.
So how would you suggest to do it? Making an example that we harvested our septal extension, placed our cartilage inside. How would you suture the cartilage itself, and where are you suturing the cartilage?
So basically, I am using like a J strut. So if you have time, I can show from my talk. Okay.
If it's not a problem for you, of course. Make sure to our attendees that our colleagues has a flight, so he's making sure to provide all his effort to stay here with us and provide all his knowledge.
Thank you very much for you're so kind. Let me just try to explain it right now, okay? I'm sharing my screen now. Okay. Do you see my screen? All right. Now this patient, I harvested the rib. Now I do my surgeries in closed approach, okay? So these are the incisions. This is how we reach to the scar and everything. The section planes, I'm passing those sides very fast. The other side, this is a live surgery event, so it's the cases with the endoscopes and also the top cameras, okay? This is an endoscope camera. Okay, after we finish this section, this is Pitangi previously left. This is scar tissue. Prolines, Good. Prolines are here. You see, we just take them out. And also the septum, this section, this is a weak septum. So we need an L strut, all right? Now, how I do it? I don't use L strut. I use J letter strut. This is my J letter. I use an extension to the anterior nasal spine. This is anterior nasal spine, as you may see. Now I'm explaining here what is L, what is a J. J is in the bone. You put a small cartilage to fix your, look, there is no bone here. So in the bone, you put a small piece. Now it's a J strut, okay? Septum extensions and everything on that. Not an L. L, you can fix it to the periosteum. I don't recommend it in revisions because it's gonna move. You will end up with crookedness. If you have piezo, you put a cave and a groove inside the maxillary bone, as you see, very easy. Now we have we have a groove in the bone, not a groove, actually, it's a cage, it's a cave. So the rib, if you put something inside, can't go out, okay? You will see right now how we put it. Let's pass a little faster. Yes, this is my rib piece there. Now I'm fixing with one stitch. Now this is also premaxillary augmentation. If you have a problem with too much lengthened lips after rhinoplasty, premaxillary defects like cleft lip patients and that. So this is a very good method to just use a premaxillary augmentation. And then you cut it, chop it according to your taste. Then we go into the bone on top. Let's pass. Paramedian incisions I do with piezo, 2 paramedians. Where up to the radix, I always control up to the radix. Why? Because if your grafts are not up to the radix, then you will have a step there. Or you will have your radix not thinned up from the front. Radix is the thinnest part of the dorsum. Then your eyes are beautiful. If your thin part is here down to the lower eyelid, it's not a good thing. So we have to put all the grafts. I'm not using the instrument, but the instrument is showing me where I am. Okay, this one. I put it and check it outside if I'm on the real radix or not, which is the upper eyelid level when eyes are open. So beautiful eyes needs beautiful radix, the thinnest part of the front view. Okay, and deepest part of the side view. You have to build your noses according to this. So I go a little more on the paramedians, and then let's move on. And then we will put 2 extended spreaders, okay, into the grooves we created with piezo. Now I chop the higher parts to make it thinner. You put it inside. 1, 2. I soften the sides and the edges of the ribs with little cylindric burrs. Then you put it inside, two of them, and stitch it a little bit higher to the weak septum. This patient had a weak septum. Now I'm touching, and if I need to manage it, I manage it a little bit more. If there is something to manage, yeah, little shave it. Now you see my ribs are in the bone, laminated. And I chop one side of it. Now I'm gonna fix them to the bone. I fix it from the outside with the burr pop. You pass through the bone and the ribs together. You put the stitch, you bring them inside. The other side also. It's very easy. And then from the ribs again, you finish the knot on the right side. Your nurse is helping you. You see, they finish the knot with the bone and the ribs together. Now, this is the best way so far I know. Your ribs never warp because they are in the bone. They will listen to the bone's words. But if your paramedians are wrong, yes, for sure they can bend. It's already crooked. I mean, if your design is good and if it bends later, no, it's not going to bend. And let's come to the caudal. After this, you have the extension of the anterior nasal spine, and now you put 2 extended septum extensions to converge it. Look, this is my augmentation of the anterior nasal spine. You see? Now it's very easy to fit it here, and the other guys, to create a step, not to fall. I will show. I create a step here. Right now you see under the extended ribs, extended spreaders. Then this step will block. I don't rely only on stitches. You will see what I mean right now. Look, I create a step. This is little important part. Yeah, end to end. Yeah, end to end, not to side, because 4 grafts side to side will be super thick for internal valve. It's not gonna breathe through the nose. But end to end, but with a step. This is the step. You will see. Guys, look, this is the step here. And the rib will sit on this step. So this is a good way of doing end to end, not to side grafting. And then this is introduction of it, blah, blah. You do stitching, the T-plasty, everything. It's passed. So maybe I could be clear by myself about what is J strut rather than L strut. It's from the bone maxilla to the bone up to frontal actually. And so it's a very stable way of doing rhinoplasties with rib. And thank you. I think it's enough to just tell it.
Last question, because I am curious now. You were drilling and you were screwing a needle.
Yes.
Side. So tell me more about this. So what you're using is you just passing throughout. How you make sure it goes in the right position?
It's skills, man. When you do it once, you will do it 100%.
I mean,
So, I mean,
course.
it's a very good one. You fix it to the ethmoid bone or the bones, depends on the bone level. You know, sometimes it's too low, but you feel it first like a screw. First, with your hand, place a little hole that it's not gonna move. You know, place a little hole. Then it's gonna be in your dip, and then put the drill. It's gonna pass through it very, very fast way.
It was great. I never thought that by inserting the cartilage will help you to have a fix. I was always fascinated by the effects, you know, the smooth effect that you have on your noses. But now I can completely understand that to get into that plane and into that shape, you need to fix it. And you need a place to fix it.
Yes,
So
exactly.
Can be in the premaxillary space.
Yes.
And in the radix. Perfect.
Yeah.
So I think that by now we have a perfect step-by-step procedure, how to harvest, how to get those cartilage into place, and how to avoid complication. So make sure in summarizing is that avoid to use Prolene, try to use PDS.
More, yes.
Try to avoid bone and bone. If you suturing just 2 of those, never do transcutaneous.
Yes, if you do it just with monocrete, never long-term stitching.
Perfect. And I think that the last lesson is that cartilage made up from the ribs are different from the cartilage from the bony septum, from the septum itself. Those are full of vessels, and what you need to understand is the reabsorption can happen, and the complications are higher rates. So try to use it in a proper way.
Yes.
Correct. Thank you, Sirka, for being with us. I
Thank
remind
you
all
very
the
much for your invitation, my friend.
No, it was always a pleasure. I remind you, if anyone is interested in previous surgery from or previous ground rounds from Circa, you can find it in our international ground rounds. And if you want to learn directly from Circa itself, would you recommend any future congresses that you are attending, any live surgical events that you would like to suggest?
Right now, I'm flying to Istanbul for live surgery revision rhinoplasty meeting. So it's gonna be good for us if you can have it with online consultation also. It's Emre İlhan's Congress, Surgical Academy. So maybe there's nothing.
Do you have any appointment for on January or February?
Yes, for sure. Yeah, for sure. So I
Great.
mean, January and February. For example, in February, I go to Cuenca, Ecuador for live surgery. I'm gonna do a live surgery there again, fourth rib revision. Tomorrow I'm gonna do in Istanbul again, fifth rib revision case, another revision, a live surgery. These are, and also I'm gonna go to Ankara, Eren Taştan's meeting in April. I'm gonna do a live surgery. And then I'm gonna go to Brazil, do a live surgery in June. So I'm doing some live surgeries around. Yeah.
Great. Thank you, Serkan, for being with us. Next appointment tomorrow with Luciana Cano. Thank you again. If you're
Thank you
interested,
very much for everything. Thanks, my